This unit will be on the epidemiology of periodontal disease. To understand the epidemiology of periodontal disease, we first need to understand how the disease is measured and indexed. So for that purpose, we are going to describe the characteristics of an ideal index. And I'm going to describe the different parameters that an ideal index should have. First would be validity. Validity refers to whether or not a measurement measures what is intended to measure. For example, if you're measuring pocket depths, then in the study you should actually measure pocket depths. So the instrument should be a valid measure of what a pocket depth is. The second is practicality. The index that's being used should be cheap and easy to use under a number of different conditions for which it was intended. If the index is not easy and cheap to use, most people aren't going to use it, and therefore the information that you glean from it will not in fact manifest itself. Reliability. I know you've learned some of these terms from your epidemiology in the EBD course, epidemiology course with Dr. Holscher and Dr. Weider. And I hope these terms are familiar. If not, please go back and take a look at them, or you can Google them or do other things to find out what these terms are. Reliability refers to the ability of an index to measure over and over what it was intended to measure, so be reliable. Doesn't mean that the information is accurate, it just means that the information is the same over and over and over again. Another important element of an index is the ability to quantify the measurements that have been made. So for example, if you're measuring pocket depth, you should be able to in some way sum up those values using things like the mean, mode, and median, and you should be able to carry out statistical measurements on those values for evaluation's sake. Another important element is sensitivity. Sensitivity is the ability of an index to measure what it was intended to measure. In other words, to capture all of those individuals who have a particular characteristic. So for example, if you're measuring everyone who is over 6 feet tall, your index should measure everyone, no matter how much taller they are than 6 feet. So it should include everyone who is at least 6 feet tall. The clarity of an index is the criteria that's used for scoring. It should be logical and spelled out so that the investigator or the person doing the measurements can easily sit down and do the measurement every single time the same way. Simplicity refers to the ease under which the survey instrument can be used in the field or under survey conditions. If it's not simple, people are going to mess it up and they're not going to be able to do it properly. So you have to keep the survey simple and the methodology simple. Objectivity. A person who is providing the survey results or doing the survey should be able to apply the information or to apply the techniques without bias from the operator. In other words, the operator shouldn't have much leeway to determine how the instrument is to be used, and it should be used the same way all the time. And acceptability. This refers to the patient. In other words, will the patient accept the particular instrument that's being used because it is either non-threatening or not embarrassing to the patient. If it hurts, the patients won't accept it, then you're not going to be able to carry out your study or do your examination. So it should be something that patients will accept so that they will in fact participate and make your study more valid and easy to carry out. One of the things that we measure in periodontics includes plaque on tooth surfaces. One of the most famous index for measuring plaque is the plaque index by Silness and Lowe. And that plaque index is measured at the gingival 1/3 of the tooth surface, as you can see by the diagram on the right. The index is scored from 0 to 3. 0 means there's no visible plaque on the tooth surface on visual inspection. And you do not do anything else but look at the tooth surface to see if there's plaque present at the gingival third. A score of 1 means there's no visible plaque on the visual inspection, but there is plaque that accumulates on the probe when you sweep the probe onto the tooth surface, and it comes off with plaque on it. A score of 2 means that there's mild to moderate plaque on the tooth surface at the gingival area that can be seen very easily with the naked eye. And in 3 would be heavy plaque filling the gingival crevice, thick plaque, and also plaque in the interdental area, which is sometimes filled with debris as well. So again, the plaque score has scores that range from 0 to 3, and it involves the gingival 1/3 of the tooth surface, and it's used for evaluating a patient's hygiene status. We do not use the plaque index here at the school, not the one by Silness and Lowe. So for historical purposes, it's important because many studies will use the plaque index, and you will need to understand what that is to be able to understand the investigations. Other schemes for measuring plaque include, but are not limited to, the Simplified Oral Hygiene Index, or OHI-S, system by Greene and Vermillion. And in this system, it's slightly different. The tooth is divided up into 3 sections. There's an incisal, middle, and gingival third of the tooth surface, and the scores are from 0 to 3 as they were with the plaque index. 0 being no visible debris or stain on the tooth. 1 would be debris or extrinsic stain covering up to 1/3 of the tooth surface. And 2 would be debris or extensive stain covering between 1/3 and 2/3 of the tooth surface. And in 3 would be debris covering more than 2/3 of the tooth surface. Now, the teeth used in this are the first tooth distal to the second bicuspid. This is the buccal of the upper and lingual of the lower, and the buccal of the maxillary right and left lower central incisor. And the reason that some people use a modification of the number of teeth there is that it makes it easier to conduct a survey because you don't have to do 28 or 32 teeth. So it's a little bit simpler to use than evaluating every single tooth. There are some advantages and disadvantages. Some of the disadvantages include you may miss certain teeth that might harbor more plaque, while the ones that you selected for an index might in fact harbor less plaque, or vice versa. So that's one of the downsides that we might discuss as we go through. There is a second component to the Simplified Oral Hygiene Index by Greene and Vermillion, and this is a calculus component. We don't use, again, this technique in our clinic or at the school, but I think it's important for historical purposes that you understand what these components are. I'm not going to spend a lot of time here except just to simply describe it, and that is score of 0 would be no calculus present, 1 would be supragingival calculus covering not more than 1/3 of the tooth surface, or 2 supragingival calculus covering 1/3 to 2/3 of the tooth surface, or with individual flecks of subgingival calculus, as you might see on the diagram, the little pink things that are below this, the cemento enamel junction on the diagram, or 3 supragingival calculus covering more than 2/3 of the tooth surface, or subgingival bands of calculus. In other words, there might be a ring of calculus around the entire tooth surface subgingivally. Now, the plaque score by Lenox and Kopcyzk, and this is modified from O'Leary. This score essentially measures whether or not there's plaque on the surface of a tooth, and you see all 32 teeth are represented in the diagram, and you simply measure the number of surfaces with plaque, the number of sites with plaque, if you will, and divide it by 6 times the number of teeth that are present and multiply times 100 to give a % score. And this is probably fairly similar to what you're doing in the clinic. And this again gives you a measure of how much plaque or the percent plaque covered surfaces in the mouth. Now, in addition to measuring plaque or debris accumulation on tooth surfaces, it's also important to measure the level of gingival inflammation, since we are really concerned in periodontics about inflammation and what that inflammation could lead to in terms of loss of attachment for the patient and eventually loss of teeth. One of the most famous indices was also created by the same group, Low and Silness. And this index again measures the gingival 1/3 of the tooth surface. 0 score would be normal gingiva with no signs of inflammation. A score of 1 would be mild inflammation, which shows slight erythema and gingival enlargement, but there's no bleeding on gentle sweep of a periodontal probe. In other words, the periodontal probe is inserted gently into the pocket or to the sulcus of the tooth, and then it's swept along the internal surface of the sulcular epithelium. And a score of 2 would be moderate inflammation, meaning moderate erythema, edema, glazing of the surface. In other words, you can see sort of a glazing or a shiny surface to the gingiva, with bleeding on gentle sweep of the sulcus. So in this case, when you do that same sulcular sweep, gingival bleeding may actually occur in this case. So you would have what we call moderate gingival inflammation. And a score of 3 would be severe inflammation, and this is marked by severe redness, swelling, edema, ulceration, and a tendency to bleed spontaneously. I've been doing this business for many years now, and you rarely ever see a situation where someone bleeds spontaneously. But it is possible. Talk about nug type cases where you blow air on the tissues, and the tissues will bleed very easily. Usually if someone bleeds spontaneously, there's most likely some sort of a systemic problem, and that's something that probably should be investigated very thoroughly with the patient and or the patient's physician. The gingival score is similar to the plaque score. The gingival score measures the number of sites with bleeding, again divided by the number of surfaces that are present. In this case would be, you multiply it times 6, which would be the number of areas on the teeth that you would examine. It would be mesial, buccal, and distal buccal. It would be mesial lingual, and distal lingual surfaces times 100 to give you the percent score for the individual. Again, this index is useful to get a very quick assessment of how much bleeding occurs in the mouth. Some of the earlier investigations evaluating the prevalence and severity of periodontal disease used what's called the Periodontal Index by Russell. This is an index that's not used very much today, but it is something that you might see in historical literature. And this was designed to be used under survey conditions and very quickly. And it used an index of 0 through 8, but it was somewhat staggered. These are not evenly spaced scores. A 0 would be, again, this is all a clinical evaluation. There is no physical measurement of the patient. This is simply an observation of the patient. A 0 would be negative, and as in healthy periodontium with no overt damage based on observation. Mild gingivitis would be overt inflammation in the free gingival margin, but not going all the way around the tooth. Gingivitis would be inflammation that goes completely around the tooth. Gingivitis with pocket formation would be a break in the epithelial attachment with pocket formation. But it was unclear how they measured this because they didn't use a periodontal probe to actually do the measurements. An 8 would be advanced destruction with loss of chewing function. The tooth might be loose, might have drifted around. There might be a dull thunk or a dull sound or percussion rather than a sort of a sharp sound that might be made with a tooth that is normal in terms of its periodontal support. The tooth might also be depressible in the socket. Now, this instrument is not used very often because it's difficult to quantify, and there's no way to measure attachment loss based on this particular index. So it has limited applicability at this point. But again, it's included for historical reference. Now, to make the index a little bit more useful, or the Russell index a little bit more useful, Ramfjord came along and sort of modified the system using the first three components of the index, but adding to that component at the bottom, which is 4, 5, and 6, loss of attachment from the cemento enamel junction, which is less than or equal to 3 millimeters, and 5, loss of attachment from the CEJ of 4 to 6, and then number 6 would be loss of attachment from the CEJ of greater than or equal to 6 millimeter. In addition to that, Ramfjord used index teeth, and these are affectionately called the Ramfjord teeth. And these are tooth numbers 3, 9, 12, 19, 25, and 28. In the international system, they're listed by quadrants first. The first number would be the first quadrant. For in the parentheses, you'd see 16. Well, that actually refers to the first quadrant in the sixth tooth from the midline. So that would be tooth number 3. And number 9 would be the second quadrant, the first tooth from the midline, going posteriorly. And 12 would be tooth number 24, which is the second quadrant, the fourth tooth from the midline, and so on and so forth until the fourth quadrant, which is number 28. 44 will be the fourth quadrant, the fourth tooth from the midline. And this particular index has been used many, many times over, and the Ramfjord teeth have been used in many surveys over the years, and they have been shown to be relatively good at determining extent and severity of disease, and we'll talk about that. Because it's so difficult to do some of these surveys in the field, the World Health Organization came up with something that was called the Community Periodontal Index of Treatment Need, which is CPITN for short. And this is a situation in which the teeth are broken up into sextants. As you can see, there are 3 in the maxilla and there are 3 in the mandible. And that's very useful because the examinations that are done by sextants, and so each sextant is recorded separately, and then they are evaluated separately. And we'll talk about that in the next slide. Now, the CPITN is done slightly differently in different age groups. You can see on the top that these are subjects who are less than 20 years old. And you can see the teeth that are evaluated in the maxilla are tooth numbers 3, 8, and 14, and in the mandible 30, 24, and 19. Notice that the second molars are missing from younger subjects as opposed to older subjects. In the bottom, you can see that in the maxilla would be tooth numbers 2, 3, 8, 14, and 15. In the bottom, there would be 18, 19, 24, 30, and 31. And so these are the teeth that are evaluated within each sextant. The first sextant obviously would be the far left, which would be the upper right side. Number 8 would be in the middle sextant. 14 and 15 would be in the left sextant and the maxilla. And the same corresponding ones would be located in the mandible. 19 and 18 would be the lower left. 24 is the anterior. 30 and 31 would be the lower right sextant. And so those are the only teeth that are evaluated for periodontal problems. And the single score is recorded for each sextant. Now the question might be, what do those numbers mean? Well, as you can see, I've listed in boxes here at the top the different sextants, 1, 2, 3, 4, 5, and 6, and I've listed the codes here at the bottom. You can see that the code of 0 means that someone with those index teeth evaluated would have a healthy periodontium. Pockets would be less than 3 millimeters. They'd have no plaque, no calculus, and no retentive factors like overhanging restorations or bulky margins or grooves in the teeth, etc. A score of 1 would be gingival bleeding on probing. 2 would be calculus or other retentive factors that are present on the tooth. 3 would be pockets that are 4 to 5 millimeters deep, and 4 would be pockets that are greater than 6 millimeters deep. And a slash through the box would mean that there is less than or equal to 1 tooth in the sextant, so it's not measured. Now, the CPITN was designed for evaluation, a quick, rapid evaluation of a patient, but it can also be used to determine treatment to some extent. And if you look at the codes for treatment, you'll see that the scores go from 0 to 3, as opposed to in the previous slide. And it goes from 0 to 3, meaning that if someone has a 0 for CPITN, they would need no treatment at all. A treatment of CPITN of 1 means that the person would need oral hygiene, because there's no calculus present and the pockets are shallow. They really wouldn't need any scaling and root planing, for example. Treatment need of 2 means that there's calculus or other retentive factors present, and that person has a CPITN score of 2 or greater. And so they would have pockets that are 4 to 5 millimeters. They'd need professional scaling and root planing to help reduce inflammation, but they would not need more extensive treatment. And that would come in TN3. TN3 are pockets of greater than or equal to 6 millimeters, and that person might need extensive scaling and root planing or some type of surgical therapy to treat their periodontal needs. This is just an example, a clinical example, showing you how the coding system works for the CPITN. You can see that the probe is color-coded, meaning that it has a clear band that goes up to the first measurement level, and that tells you whether or not it is 3 millimeters or less. Okay, and then it also looks for no calculus and no defective restorations, and the gingival tissues in this instance are healthy with no bleeding and probing. Now compare the previous slide with the slide that you see here. Notice that it has a code of 1, which means that there is bleeding and probing, but again there is no calculus present, no defective margins, and notice that the black line in the probe is still clearly visible. So it's still within that code of 1. Now this is an example of code 2. Now you notice that the colored part of the probe still remains visible, but there is super or subgingival calculus and or defective restorations present. You probably notice that there's a mesial amalgam restoration on the tooth. So that would be something that would clearly be important to note, and we would have to make sure that this person is treated for that overhanging restoration. So again, treatment would be oral hygiene instructions, subgingival plaque removal, calculus removal, and correction of the restoration. So this would be a code 2. Now a code 3 clearly shows that the black portion of the probe, if you look at the clinical slide, the black portion of the probe is partly visible. Okay, so which means that now you've gone past that level where you would be a code 2. So now you're code 3. Okay, which means that comprehensive examination is required, charting, full charting is required of that sextant, periodontal therapy is administered in addition to oral hygiene instruction, scaling and root planing would be necessary. It may not be necessary for more extensive treatment at this point, but clearly some intervention is required at this point. Now a code 4 indicates that the colored area of the probe completely disappears under the gingival margin, which means that the pocket depth now is greater than 5.5 millimeters. Okay? So in this case, full mouth periodontal exam is required, and treatment obviously is going to be necessary because the pocketing is deeper than what would be manageable by general oral hygiene instruction, and probably by simple scaling and replanning. The patient would probably have to be anesthetized, and the scaling and replanning subgingivally would take place, and reevaluation would take place after that. And if necessary, the patient might end up having surgical therapy as well to manage. Going forward, we're going to talk now about the extent and distribution of periodontal disease. It is difficult to evaluate the full extent of periodontal disease in its natural state, because most people end up having treatment for periodontal disease over time. So it does interfere with the natural history of periodontal disease. However, a very famous study that was done by Periodontal and co-workers that looks at periodontal disease in a group of untreated male Sri Lankan tea laborers. And this was a study that was conducted over a number of years to look at what happens to periodontal disease that is not treated over time. And what happens in those individuals, as you can see from the charting, is that despite the fact that none of them were treated and they were basically left to their own devices, that there ended up being 3 different groups of individuals that were identified within the group of individuals with no treatment. And there was a group that were called the slow progression, and that was about 11% of the population. And there was a moderate progression group, which represented most of the individuals, or 81%. And then there was a rapid progression group, which represented about 8% of the population. And you can see by the slide that there is a very distinct difference in the pattern of loss. You can see that the slow progressing group, although there were sort of undulations up and down, the overall projection is fairly slow and steady. Whereas the moderate group was on a little bit higher trajectory. But you can see that on the rapidly progressing group, that trajectory is not quite the same, and it shows a very rapid progression of disease with age group. And notice here that it starts fairly early in the 20-year-old age group, and then it goes all the way up to the individual just prior to 40 years of age. And again, this shows that there was a difference within the group, even of those individuals who were not treated at all, that identified very clearly different patterns of disease. And that will become very important in our discussion of aggressive periodontitis versus chronic periodontitis. But of course, it's difficult to talk about periodontitis without also talking about missing teeth. The ultimate problem with periodontitis is that if left untreated and left long enough, it oftentimes leads to loss of teeth. And this slide shows the mean tooth loss at different age groups for the different progression groups. And you notice that the slow progression group lost the fewest number of teeth. The moderate progression lost slightly more teeth, but you can see clearly that the rapid progression group lost the most teeth, which means that they lost most attachment, which resulted in tooth loss fairly early in their lives. This is important, again, because it shows that link between attachment loss and continued destruction of the periodontium over time and eventual tooth loss. Now, clearly, other things can cause teeth to be lost, caries, etc. But in this group, interestingly enough, there was no reported caries lesions. So all of the tooth loss essentially was due to either periodontal disease or trauma. Since we don't have an accurate report of trauma in the group, we assume that most of the tooth loss was in fact caused by periodontal disease. Now this slide essentially compares the Sri Lankan group, which you can see on the far left, with other groups, and these are indigenous people of the Amazon rainforest. And if you can see, and also compared to the Norwegian group, which was the parallel group that was used to initially compare the Sri Lankan tea laborers. As you can see, for mean attachment levels, that overall the Sri Lankans had significantly more attachment loss initially at the, say, age of up to 35 years old compared to the Tongans and Samoans, which obviously increased over time, as well as the Tanzanians and the folks in the Amazon, which are in the sort of the blue color. Compare that to the United States, which is lower than the others. I present this here just to show you what different amount of attachment losses can be found in different populations, and just to show you that, again, there are outliers such as the Sri Lankans and also the Tongans, which are sort of in the yellow. But we see a range of patterns of disease over different time periods and also in different places. Access to care may play a large part in terms of how much damage and loss takes place over time. One of the elements I think is important to understand is the way in which indices are measured. And there have been a number of ways. We talked about one of them. We talked about the Ramfjord teeth, and these are all partial measurements what we talked about. The Ramfjord teeth do not include all of the teeth, and I've listed the teeth here again for you. I won't repeat them, but there are some advantages and disadvantages. Well, one of the advantages is that it's easier and faster than a full mouth examination, and it's reasonably accurate for the extent and severity of periodontitis and gingivitis. However, a disadvantage is that like most partial indices, it tends to underestimate the prevalence of periodontal disease. And if you really are interested in obtaining an accurate assessment of the periodontal disease status, then this is going to be something that might come up short for you. But understanding that and putting it into perspective, it would be important if this type of an index is to be used. Others have used a random half-mouth measurement, and what this is assessment of one random upper and one random lower quadrant. Most surveys will use only the buccal site, and unfortunately using the buccal site has some advantages and some significant disadvantages. It's easy and fast to use. It's faster than using a full mouth examination. And it's also reasonably accurate for extent and severity of periodontitis and gingivitis. But the disadvantage, again, like the Ramfjord teeth, is that it underestimates the prevalence of periodontal disease. And remember that sites that are more difficult for patients to access are the likely sites that are going to end up having more periodontal disease than the sites that are easy to access. Interproximal sites on the lingual surfaces are much harder for patients to clean than buccal sites. So therefore, you would expect more disease to occur at those sites. If you, in fact, don't measure the disease at those sites, then it becomes much more difficult to get an accurate picture of how much damage is taking place in an individual's mouth. So that's one of the downsides that one has to evaluate when doing a random half-mouth.
Every few years, the health of the population in the United States is evaluated by the Centers for Disease Control. And in this particular case, the survey is a multi-sample, multi-state locality probability survey, which includes individuals who are 30 plus years of age from all 50 states and the District of Columbia. This is a very complex survey that's been worked out by a number of demographers and statisticians with the help of periodontists and non-periodontists, including statisticians and others, who are affiliated and associated with the conduct of this particular survey. Now, this particular survey includes roughly 7,066 individuals, and that includes from the years 2009 through 10 and 2011 through 12. So those are the most recent surveys that have been conducted, and some of the results from those surveys will be described in the next few slides. The breakdown is for severity of periodontal disease. Will include basically several types of periodontal disease, and these include severe disease, as I've given you the definition earlier, and non-severe disease, and that includes moderate disease and disease that is less than moderate or mild disease. But the two lower categories, the mild and moderate disease, will be classified as non-severe or other. And if you read some of the materials on the diseases and on the classifications, you will find that these are the categories that are listed, severe and other. And so we'll go through a number of potential risk factors or areas in which the disease has been separated into, including age, gender, racial and ethnic group, education status, poverty level, marital status, and smoking status. We're not going to cover each and every one of them, but we will cover most of them in the following slides.
Now, the examination protocol included measurements for gingival recession, which was measured as the distance from the free gingival margin to the CJ, pocket depth, which is the distance from the free gingival margin to the bottom of the pocket, and the probe that was used was calibrated at 2 millimeters, 4, 6, 8, 10, and 12. The measurements, all measurements were rounded to the lower whole number. So if a probe went between 2 and 3, it would be recorded as a 2. Okay? If it were between 10 and 11, it would be recorded as 10. Then loss of attachment was essentially a calculated value of the difference between probing and recession. Now, the measurements in this particular survey, which is a departure from the previous surveys that were done, and you'll read in your textbook, they talk about other NHANES surveys. But this particular NHANES survey, which is not included in your textbook because it's too recent, they measured 6 sites on each tooth. They measured the mesial, distal, and mid-buccal surfaces. They measured the mid, distal, and mid-lingual surfaces for all teeth, excluding third molars. So every tooth that was present was evaluated. And people included in the survey included anyone who had at least one tooth present. So people who were edentulous were not included in the survey because this was, again, an evaluation of periodontal disease. Severity of periodontal disease was determined as follows. Severe disease was considered 2 or more interproximal sites with at least 6 millimeters loss of attachment and 1 or more sites with interproximal loss. Moderate was considered 2+ interproximal sites with greater than or equal to 4 millimeters loss of attachment and 2+ interproximal sites with probing depths of greater than or equal to 5 millimeters, but not on the same tooth. And in mild was considered 2+ interproximal sites with greater than or equal to 3 millimeters loss of attachment and 2 interproximal sites with greater than or equal to 4 millimeter probing depth, not on the same tooth, of course, or 1 site with greater than or equal to 5 millimeters. Now, they did not make the determination of the severity of the disease on site. These measurements were made by hygienists who were licensed within the state that they, at least one state in the United States, and these measurements were made in the field in mobile units, and then these measurements were taken back and they were evaluated later. So severity of the disease was determined after the evaluations were done in the field. So the individuals who were doing this would not have had to determine whether or not it was mild, moderate, or severe periodontitis.
This slide shows the summary of results showing gender and age groups. And as one can see, males have more total periodontal disease or total periodontitis than females, and they also have more severe periodontitis compared to females, as well as non-severe periodontitis. This is a general trend for men in general, showing that men typically have more disease than women, and as you can see, the breakdown in the severe categories suggests that that disease is several times greater than for women. And it's also in the non-severe category where you can see that although it's not twice as much as it is for the severe category, it does point to the fact that men typically have more periodontal disease than do women, as indicated by the total periodontitis column in the far left. It also shows periodontal disease by age group. And generally speaking, one can see that periodontal disease typically increases with increasing age group. And you can see, although the age groups are slightly different in terms of their categories, meaning those that are 30 to 34 years of age only have a 5-year age category, whereas those that are 35 to 49 have almost a 15-year age difference, and those that are 50 to 64 as well. So even though these groups are not equivalent or even, one can see as a general pattern that periodontal disease increases with the increasing age group, and that probably represents the fact that exposure increases over time as well. So you can see that there's an increase in disease as long as the individuals continue to have exposure to pathogens and have exposure to time. So you have more pathogen exposure and you have more time for that disease to actually take hold and end up causing more damage. This slide is the continuation of the summary of results showing racial and ethnic groups as well as education. And one can see that for total periodontitis amongst racial groups, you can see that the Hispanics have a higher prevalence of periodontal disease at 63.5% versus non-Hispanic Asian Americans. And this data for Asian Americans is only for the 2011 and 2012 categories, rather than from the 2009 and 2010 categories. There was no data for that group in 2009 and 2010. And the non-Hispanic whites have 40.8%, and non-Hispanic blacks is 59%. So again, what you typically see is that groups that tend to be lower on the socioeconomic scale tend to have more periodontal disease than those who are on the higher socioeconomic scale. But in general, if you look at other studies that show disease category based on how well people practice oral hygiene, the better oral hygiene, the less disease, regardless of ethnic group or racial group. And also for severe disease, what you can see is that for the Hispanic group, there's 15.8%, and in the non-Hispanic blacks, it's 15.6%, basically equivalent percentages for severe periodontitis. And you also see very significant and almost equivalent numbers for the non-severe periodontitis group at 47.7% and then 43.5%. The numbers are similar for non-Hispanic Asian Americans and non-Hispanic white for the non-severe periodontitis, but you can see the non-Hispanic Asian Americans have almost twice as much in the severe periodontitis category compared to non-Hispanic whites. Now when we look at education, we see that Individuals who have more education tend to have less periodontal disease. Look at the total periodontitis category and see for those with less than a high school education, 67%. Those with more than a high school education, 37.2%, almost half the number. And in fact, if you look at severe periodontitis, those with higher education, greater than high school, 5.7% versus 17.1% for those who have less than a high school education. So again, suggesting that there's a much greater likelihood of having periodontal disease if you have less education. And that is true again also for non-severe periodontitis, although the numbers again aren't twice as much or greater as they would be for those in the severe periodontitis category. The story is very similar for individuals who are at varying levels of poverty. You can see for those individuals who are less than 100% of the federal poverty level, which is FPL, you have 62% of those individuals with periodontitis compared to 33% of those who are greater than or equal to 400% of the poverty level. And so that's about half, roughly, as many people or percent of people with total periodontitis who are at the upper echelons of the economic scale, in this case greater than or equal to 400% of the federal poverty level. You can also see that, again, that affects severity of periodontitis. Look at the next column, it shows 4.9% for those who are in the 400 or greater FPL versus 14.9% for those who are less than 100% of the federal poverty level. And the numbers, again, speak volumes in terms of the non-severe periodontitis as well. 47.4% of those who are less than 100% of the poverty level versus the 28% for those who are greater than or equal to 400% of the poverty level. And also, if you look at the current smoking status, you can see that smoking does appear to have some impact on severe periodontitis, although we didn't cross-reference some of the others like poverty level, age, gender, and so forth in these particular evaluations. We can still see that current smokers have 18.9% severe periodontitis versus non-smokers who have 5.5%, and then those who are former smokers are somewhere intermediate in between those at 9.5%. For non-severe periodontitis, the numbers are higher for current smokers. You can see 47.7% versus 32.8% for those who are non-smokers. So we can see that smoking appears to have some effect on periodontitis, and in fact many studies that show smoking does have a significant effect and may be one of the greatest preventable causes of periodontitis. But we'll get to that in another slide. One of the fundamental ways that we look at periodontal disease and evaluate severity is by attachment levels. And this particular slide shows severity of disease by attachment loss by age group. And what we see in this case is that amongst the different age groups, the severity pattern is roughly the same, although the amount of disease actually increases by each group. So if you can look at the 30 to 34-year-old age groups, and by the way, the numbers in the parentheses represents the number, so the mean number of teeth per age group. If you look at the bottom under the categories, and as you can see, for those who are 30 to 34 years of age, they have 26.5 teeth on average, etc. For the other categories. But I think the general trend is that if you look at the number of individuals or percent of individuals per category, that number increases with increasing age. So if you look at those who are greater than 3 millimeters, which are in the pink, you can see that number increases over time for the different age groups. And you can see those that are 4 millimeters greater than 4 millimeters, that also increases, as does the other categories, including those who are in the greater than 7 millimeter category. So over time, what tends to happen is that people tend to get disease, and they tend to increase their level of disease over time. And so that's the fundamental outcome of what you're seeing on this particular slide. This slide is a graphic illustration of severity of periodontal disease by age groups. And it's basically what I showed you before, that over time, as you can see in the pink bars, over time, total periodontal disease increases, and the severity of periodontal disease also increases. You can see in the yellow columns, and in the sort of grayish column, the non-severe periodontal disease also increases. As you probably noticed, that the total percentages for the severe and non-severe equals the overall periodontitis group.
So, what do we know about age? Well, we know that age doesn't cause periodontal disease, but it is associated with an increased prevalence and severity of the disease over time, due primarily to the exposure that people have over time, and not, and I repeat, it is not a causative factor in periodontal disease, but it is clearly a phenomenon that none of us can escape. As we get older, we have lived longer, so therefore we have been exposed longer, and that's simply a function of time.
The take-home message from this slide, showing periodontal disease by severity and gender, illustrates that males have more periodontal disease in all categories, overall severe and non-severe, than females.
So again, while gender, there is consistent evidence to point towards males doing worse than women, the difference appears to be more behavioral, meaning that females tend to have better hygiene, they tend to also practice better health-seeking behaviors, and therefore tend to do better than men. We don't believe that there is any other reason why there's a difference in genders, because to take the same level of plaque, people do equally poorly or equally well, regardless of gender.
This slide basically shows the severity of periodontal disease by racial and ethnic group. What it basically shows is what I showed in a few slides earlier, is that there is a disparity amongst those in the Hispanic and non-Hispanic black groups. Basically showing that there's a higher percentage of individuals with periodontal disease in those groups, both in the total amount of periodontal disease or periodontitis, and also in severe periodontitis, as well as in non-severe periodontitis. So while surveys in the U.S. tend to show poorer periodontal disease among Hispanics and non-Hispanic blacks, the differences between the groups appears to be associated with limited access to dental care rather than differences in ethnicity or race. And in fact, if you look at individuals based on care that they receive or hygiene that people perform, it tends to be much more related to hygiene of the individuals rather than through ethnicity or through race. One of the most consistent findings in the periodontal literature is that individuals who smoke tend to have more periodontal disease than those who don't smoke. And this is true for all categories, for the overall category of periodontitis versus those with severe or non-severe disease. Smoking tends to increase the prevalence of periodontal disease, although smoking itself does not cause periodontal disease. It is clearly a risk factor for periodontal disease, meaning that individuals who already have periodontal disease would tend to have more periodontal disease if they in fact smoke. So smoking could be considered a risk factor for periodontal disease rather than a cause of periodontal disease.
So tobacco use has been shown that smoking is a risk factor for periodontal disease. And evidence points that smoking is one of the strongest modifiable risk factors that we have. And if we could get rid of that based on the old data that was present, we'd get rid of nearly half of all periodontal disease, or at least bring that half down to the level of people who were non-smokers or non-tobacco users. So tobacco is a predictor of future periodontal disease and treatment outcome, meaning that there's poorer treatment outcomes among people who smoke compared to people who don't smoke. So periodontal scaling and replaning, surgical therapy, all of those have a more negative outcome among smokers compared to non-smokers. How about oral hygiene? We push and push and push oral hygiene very, very hard at the school and as periodontists to the general public to decrease the chances of having periodontal disease. And what we know from the literature is that the lack of proper home care has been shown experimentally to cause gingivitis. And that was, I think you saw that in one of the previous units with Dr. Dobus's presentation on the experimental gingivitis by Dr. Lowe's group. But what we haven't seen is that it has not been clearly established as a strong risk factor for periodontitis. Now, I know this statement seems like it's a contradiction, but there really is no experimental evidence to show that lack of proper home care or hygiene causes periodontitis. We know that it causes gingivitis, and we know that no one who progresses to periodontitis will escape having gingivitis. In other words, everyone who goes to periodontitis will have gingivitis. But we don't know whether or not if a person doesn't brush and has gingivitis, that will in fact proceed then to periodontitis. There's just no evidence to support that at this time. So while it's important to reiterate to patients that hygiene is very important at eliminating or the risk of or reducing the risk of having gingivitis, it's still unclear whether or not reducing plaque levels will in fact translate into a reduction in periodontitis over time. Now, periodontitis is also associated with a number of other conditions, one of which has one of the strongest relationships is with diabetes. Now, evidence from cross-sectional and cohort studies indicate that subjects with poor control of their diabetes have more extensive and more severe periodontal destruction than subjects who are well controlled. And that's fairly consistent, even though not every study shows that. Most studies do show that relationship. And it's important to note that that relationship, we believe, it can go in the other direction as well. In other words, we also know from a number of studies that people who have periodontal disease have a much harder time controlling their diabetes because of some of the mechanisms that we'll talk about in another session that tends to make diabetes a bit worse based on some of the ways that the cellular immune system works, and we'll talk about that in another session. I know we talked about periodontitis associated with systemic conditions in the past when we talked about diagnosis. Now, in this case, HIV infection. Some of the very early studies when HIV was just starting out, we correlated T lymphocyte levels with increased severity of risk for periodontal disease, or chronic periodontitis. And that was CD4 T lymphocyte, CD4 counts of less than 200 cells per microliter. And that was associated with increased severity of disease. But recent evidence suggests that HIV infection by itself doesn't increase the risk for periodontitis. Part of that might be that the improved treatment with the HART regimen, or the HART regimen for HIV-infected patients might have improved the likelihood that they would have less damage and less disease over time, because the management of these folks have gotten so much better that might put them at less risk for having some of the more exaggerated problems that we're seeing early on, meaning the severe soft tissue and hard tissue damage that occurred for people who had AIDS, frank AIDS, early on in the epidemic of HIV infection. Osteoporosis has been another one of these conditions that have been somewhat linked with periodontal destruction, in particular alveolar bone loss and periodontitis. Now, while many of the studies did show a relationship between bone loss and periodontitis and osteoporosis, we still don't have a lot of large, well-controlled prospective studies. And so the current relationship between osteoporosis and periodontitis still remains a bit unclear. So the verdict is out, and we still need to wait to get those large studies to be able to determine whether or not this is in fact a true relationship, and we need to continue to unravel this relationship so we can see exactly how osteoporosis affects periodontitis, if at all. Nutrition has been something that people have looked at for a number of years to evaluate whether or not that affects periodontal disease status. With the exception of a few conditions like severe vitamin C deficiency and scurvy, and severe malnutrition amongst children in underdeveloped and impoverished countries, there's very little evidence that nutrition has a major impact on periodontal disease. In the first instance, in vitamin C deficiency, scurvy, it's associated with severe gingivitis, where you have bleeding on probing, and the tissues start to show signs of breakdown of the marginal tissues. That's typically not seen with periodontitis, though. And under those severe conditions of malnutrition, severe malnutrition, nug-type lesions, which develop into noma, which is a really severe form of the condition that recurs over and over again, destroys large amounts of bone and periodontal attachment, but is rarely seen in developed countries and mostly seen in impoverished countries. So again, the evidence for nutrition does not seem very strong at this point with periodontal disease. Stress. Stress is one of those factors that is very, very difficult to escape. It's considered to be a risk indicator, meaning that we don't know yet whether it's a risk factor, but we think that it might be based on the evidence. We think it's a risk factor for periodontal disease, and it may act to modify other behaviors like, good oral hygiene, or it might increase the person's alcohol use or tobacco use. We do know that it leads to higher glucocorticoid and catecholamine levels in the body, which in turn could affect hormone levels and immunological makeup levels in the body. And these indirectly could lead to increased periodontal damage or destruction. And most of the studies, unfortunately, are either cross-sectional or case control, and they have inconsistent methodology that's been used. So evidence supporting a relationship between stress and periodontal disease needs further study. But what we have found is that people who are able to cope better with their stress, everyone has stress, but those people who tend to cope better with their stress tend to have less periodontal destruction, and that seems to be somewhat consistent. But again, the evidence is still out, and we need further data on prospective studies that help us to unravel this relationship. What about genetics in chronic periodontitis? Well, a number of investigations have looked at a number of genetic components, including what's IL-1, genotype, HLA antigens, and Fc gamma receptor genotypes, as well as a number of others. And but the overall results of this research has been a bit ambiguous. In one study, investigator Ken Corman and his group have been looking at non-smoking Northern Europeans and the IL-1 composite genotype, and that's consisting of at least one copy of the less frequent allele 2 at both IL-1 alpha and IL-1 beta loci. And these individuals were shown to be almost 7 times more likely to have severe disease, periodontal disease, compared to with mild or no disease. But the results were not seen in smokers or in other populations. So for Northern Europeans, this seemed to be something that held fairly stable, but not in other groups or other populations or in smokers. So we got a large percentage of the world which does not fit into that group. So basically the evidence for genetics and epigenetics is still unfolding and may hold promise for us being able to understand how to predict and treat periodontal disease in the future. That's something I think that's going to develop in your lifetimes, in your practice careers, and I hope that it does, and stay tuned, and hopefully we'll have much better ways of managing patients and treating them specifically using their genetic makeup. Now, we have talked about aggressive periodontitis in the past, and we talk about locally aggressive and generalized aggressive periodontitis. And one of the things that seems to be fairly clear from the literature is that despite where you evaluate the disease process, it tends to be fairly low prevalence. It tends to have a fairly low prevalence across the world. And the U.S. seems to be, and in Africa, the two places you can see on the table, two places that have a fairly high prevalence of aggressive periodontitis. Most of the other groups have a fairly low prevalence of periodontitis, and I think that's important. One of the disadvantages of having a disease that's low prevalence, it's hard to study because it's hard to find enough people with the disease to be able to study it properly and to be able to devise ways of treating and managing these cases. So we don't know as much about them as we would really like to. And if we had a much larger cohort of individuals with the disease, it would make it much easier to study. And therefore you might find very different findings in one group, one population as opposed to the other. An addition of one individual might change your prevalence rate, by 50%, or in some cases more than 50%. Okay, so it's really important to understand that we do have this limitation in terms of number of individuals with the conditions. Now, I'm assuming that everyone understands what aggressive periodontitis is. If not, please go back to the chapter on diagnosis of periodontitis and make sure that you review that and then come back to make sure that you now can follow what we're discussing here. We're going to talk about a few factors that are associated with aggressive periodontitis, including age. Now, we know that the disease can occur at any age, but for the most part, the localized form of the condition usually starts in adolescence or somewhere around in the puberty years, and is usually isolated to molars and incisors, and that's where we typically start to see it. However, the generalized aggressive periodontitis usually increases in prevalence up to about 25 years of age. But age itself is not a major factor in looking at aggressive periodontitis. only from the standpoint of where people start to develop the condition, as opposed to age being the strict factor that causes the condition to happen at a particular time, because it could happen in a 35-year-old where you have rapid loss of attachment over a period of time, short period of time. How about gender? There appears to be no predilection by sex, so as many girls or as many boys tend to have the condition, so there doesn't appear to be any reason to evaluate individuals by gender at this point. Now, race and ethnicity has been a sort of a contentious issue, and there's some debate about the prevalence in different racial and ethnic groups. Large studies in the U.S. have shown African Americans to be the group that has the highest prevalence of the disease, and other studies have shown higher rates among Afro-Caribbean individuals, as well as Hispanics. Now, while it may be true that these individuals have more disease or are affected more often, it's still there's still some debate as to whether or not these individuals are truly more affected, which could in fact point to a possible genetic makeup or familial pattern of development of the disease, and that's still a little bit unclear and it has to be elucidated. As with most forms of periodontal disease, socioeconomic status has sort of been associated with periodontitis. There's little evidence here that this trend holds true for aggressive periodontitis. So it tends to be an equal opportunity condition. It doesn't seem to really care all that much about the status of the individual in terms of their socioeconomic status, and it tends to cross all of those lines and barriers. Well, what about diabetes? For aggressive periodontitis, there's not very much evidence linking aggressive periodontitis with diabetes at all. Chronic periodontitis, yes, but not aggressive periodontitis. There doesn't appear to be much evidence to support a relationship between those two conditions. My assumption might be that if a person has diabetes and happens to have the aggressive periodontitis, it might aggravate the condition, but there's no evidence or very little evidence to support a strong relationship like there is between diabetes and chronic periodontitis. However, there is a mounting amount of evidence to support that people who have aggressive periodontitis and who smoke tend to have more severe and widespread disease. It's not clear whether smoking is a risk factor for aggressive periodontitis. In other words, people who tend to have the condition and also tend to smoke tend to do worse, and they also tend to have a more pathogenic flora, those people who smoke and have the aggressive periodontitis. But whether or not it's a risk factor, there doesn't seem to be a lot of evidence to support that. At least it's not clear at this time whether that's in fact the case. Oral hygiene. Well, in aggressive periodontitis, it is not clear whether oral hygiene has any appreciable impact on the condition. While oral hygiene is good for preventing gingivitis, it's unclear whether hygiene would have any impact on aggressive periodontitis. And in fact, many of the studies that describe patients with aggressive periodontitis have shown minimal plaque accumulation as compared to individuals with chronic periodontitis. So I think it's important to recognize that the plaque that's present in these individuals may be subgingival plaque and not the heavy supergingival plaque, and they are probably very specific types of bacteria which are probably not affected as much by plaque removal as some other conditions. In addition to that, we know that the bacteria that are present in aggressive periodontitis, in particular AA, can actually penetrate into the tissue. So therefore, oral hygiene might have very little impact on the improvement of the condition. And in fact, we know that scaling and replanting in many cases has limited use in this condition, and sometimes supplemental use of antimicrobials in addition to the scaling and replanting, it tends to be more useful. With respect to genetics and aggressive periodontitis, there is strong evidence suggestive of a genetic link to the disease. The prevalence rate of the disease is greater, as we know, in first-degree relatives, meaning parents, siblings, and offspring of individuals affected with the disease, than it would be in the normal population. The disease is also a consistent feature in several genetic or inherited disorders, which tend to be associated with the disease, like Chidiac-Higachi syndrome, Down syndrome, a number of other conditions, leukocyte adhesion deficiency, a number of other conditions that might predispose individuals to more periodontal disease, periodontal attachment, and bone loss at a fairly early age. And segregation analyses implicate the role of a major gene, possibly a major gene, that might control an individual's susceptibility to the disease. And then there are several genetic polymorphisms that have been associated with the disease as well. And at least one form of the disease which co-segregates with dentinogenesis imperfecta has been linked to a specific region on a chromosome. I don't think you need to worry about this genetic component so much. We're not going to really stress that, other than to indicate that the information is unfolding at this time. We don't know all that we need to know at this point, and I think it's important that it be mentioned, but clearly there is more to be learned until we understand better what's going on with the genetic component. But clearly, aggressive periodontitis is more likely related to genetics and again epigenetics, which, as I said earlier, we're not going to really discuss all that much here as we go through other courses or you go to other seminars, etc. Hopefully we'll have a little bit more information that we can share to help you understand better how the disease functions and how it affects our immune system. Everything really is about inflammation and how our bodies manage inflammation. And if we can figure out how that happens, I think we can learn ways to modulate and mitigate the effects of bacterial contamination on the way our bodies react.